briefly, 2 minutes on the Seventh-day Adventists. In the Adventist Health Study, half of the Seventh-day Adventists don't follow what their church teach. They eat cheese, pizza, everything. But even this half of non-vegetarians and the Seventh-day Adventists, their rate is much less than the public. And the reason for that, they don't eat pork, they don't eat shrimps, they don't eat lobsters. So even though they don't follow the church's suggestion, but they still don't eat as much fat as the general public. And so their rate of diabetes is much lower. Those who follow their church's recommendation 100%, they have ridiculously low rate of diabetes. So within the Seventh-day Adventist system since June 21, 1863, they've actually recommended that they go for a walk after every meal. They recommended that they don't sleep, don't eat anything for 5 hours before they go to bed. They actually had recommendation that you live on 2 meals a day. 1867, I think, it was mentioned that Seventh-day Adventists were eating too much sugar. At that time, people were eating 10 pounds of sugar per person per year. Now we're up to anywhere from 138 to 200 pounds of sugar per year. And from way back then, the Seventh-day Adventists were saying that we're eating too much sugar. So you see, for those who follow the Seventh-day Adventist principles, they have almost none, ridiculous amount of levels in going through this. All right, so let me mention this. I spoke at length on this morning, that adverse childhood experiences have been shown 38 studies in this review showing a link to diabetes. So that must be affected. Motivational interviewing. In terms of therapy, I don't have time to go into this. All I can do is mention the name. But you must write this down and get to know what it's all about. Motivational interviewing. A patient came to my practice once, talked to her about obesity. I was chief of medicine at Baylor at that time. I went to our conference, and this lady introduced herself to me, and she said, Dr. Bryce, how are you? My name is Cindy. So she looked in my eyes, and she realized I didn't remember her. She said, you have a right to not remember me. The last time I saw you, I was a patient of yours, and you insulted me so much that I left your practice and never came back. And she was a vice president of a hospital. And I said, are you sure it's me? She said, yes. She said, but something you said to me was such an impact. You looked at me and said, if I don't do something about your obesity, if I don't do something about my obesity, I'll be dead in 10 years. And I was offended in you making that statement. And I came out to your office. I did not use motivational interviewing. She went, she lost the weight, because what I said to her, keep going. But if I had asked her, I said, do I have permission to talk to you about your weight? I didn't ask her permission. I just went right into it. In a scale of 1 to 10, how sure are you that you will start exercising? There's a whole series of techniques that you can go through in motivational interviewing. So I'm suggesting that you get to know what it is as you go through. In summary, let me see if I'm going to miss the flight or not. Okay, so calorie restriction is very important, and plant-based whole food is the only thing that I can think of in reviewing the literature that you can eat a very low-calorie diet. And I'm not talking about 500. This was just to show you that you can have dramatic reversal. But I eat about 1,200 calories a day. I ate until I was full. Dr. Dockery cooked that meal. And I was full this morning. I came here and I ate another full meal. And I did not eat more than 1,200 calories. Okay? So you can do that. Eating a lot of fruits, a lot of vegetables. Try as best as you can to front load your calories. Eat 2 meals somewhere between 6 a.m. and 4 p.m. in the afternoon. Physical activity is very important. I have decided I'm going to start running marathons. I'm not really running, walking. So I'm training now for the Countdown Marathon. Okay? Intermittent fasting, I fast every evening. I fast every evening there. I don't eat on Fridays. So 1 day a week, I don't eat. Adequate sleep is going before 9:30 tonight. I'll be in bed. Another thing is important is therapeutic relationships and engaging with motivational interviewing. These are important concepts. And in closing, let me show you. I got these slides from Calvin Essentine. The doctors who prescribe all the medicines and the big surgeries, this is what their office look like. The doctors who practice reversal medicine, they get much fresh air. This is what their office look like. However, what doctors like me, Dr. Cooper, who recommend lifestyle, then we get something that other doctors don't get. We get a chance to take people and who love to do things, and even when they're 100 years of age, we give the satisfaction to help them to carry out the same practices. And lastly, diabetes can be reversed. You can help patients to live full lives that at 106 years of age, you're still water skiing. Thank you so much.
Because of time constraint, I was saying I will make it very super easy, practical, and straightforward. Um, by the way, I'm not going to take any question, as I speak, but I will just proceed, delve in what we need to know. Now, the topic, as you know, is health promotion and disease prevention. Those are two major subjects, health promotion and disease prevention. But I must tell you right away, there's a common denominator here. We need to know it. There's no way you can talk about health promotion and disease prevention without considering the common denominator, which is health education. You need to remember that. So, the definition from Rural Health Information Hub is just to make us understand that we need to keep healthy. Health promotion is about keeping your life healthy. Disease prevention is disease avoidance. You avoid it. You don't want to have it. You live in such a way that you don't want to culminate to having a disease. It's very simple. The World Health Organization gives another definition which is more important, is to enable people. It means that you prepare them so that they may take control of their own health. Health promotion. When they begin taking control of their own health, then they can avoid, they can prevent the disease. Now, I'm going to go fast here because here is almost the same thing. Those are the things that you need to know. In case you want to have this picture, I can make it available to you. Straightforward, you just have to know it, 12 tips to be healthy is right there. I'm not going to emphasize. Here it is the same thing, health promotion. Those are the different areas. When we talk about health promotion, it's not just about, I'm going to eat healthy, I'm going to do exercise. There's a lot into it. When we talk about health promotion, we're actually trying to address the entire spectrum of human life. I was at Loma Linda as a student, and I learned that you need to consider all aspects of human life. That means at the physical level, at the mental, social, family, social, spiritual. This is a holistic approach. You deal with the entire aspect of human life, the whole person approach. When we talk about health promotion, always remember that. It's not just about what people eat. Now, I said I'm going to be very practical because I do think I've traveled a lot, extensively, in various places of the world. Last summer, I was in a little place that was in Chiapas in Mexico. No car to transport me, and that was my transportation. So I had to have this little scooter, to go with me in a remote place. And people were waiting for me. This is me, see? In the darkness, and people were there, campesino, they were there waiting for the doctor to come and talk about health promotion and education. And it was during that occasion, that's me, you see. I'm here with some people, elderly, women, and kids. And then I raised this question. Can someone tell me the definition of health promotion? La definición de la promoción de la salud. No one could answer. And I was stunned. Surprisingly, this little boy that you see flashing raised his hand. And then he gave me one of the best definitions that I treasure today. Would you like to know? You're lucky because you're here. You didn't leave. And then that little boy told me, la promoción de la salud es la salud siendo promovido. Wow! Is health being promoted? This was frankly thought-provoking to me. Health being promoted is down on me, but by who? Who promotes health? Who is in charge of promoting health? People in the colonia? No. People, members of the churches? No. Listen, I'm here, even if I see empty chairs, I see a lot of health professionals here. I'm not talking about the physician only. I'm not talking about nurses of all the allied health. I'm talking about health professionals. Everybody here is a health professional. So, what is our duty to promote health? What is our mandate? What do we do? It's really easy. Our duty as health promoters, it doesn't matter if you're a physician, you're a CEO in a hospital, you're a professor, like I am at duty at GV, it doesn't matter. Health professionals need to educate people. You need to disseminate. I was talking to a friend here, the right message. There's so many things happening in the community, the colonia, in the rural places. People don't know. But we are the one to get the right message and to impart it in a simple way. I'm not talking about a lot of science here. They want to know what works, what is there. Communication, education. If I'm a politician, I'm also in charge. I need to make laws that will allow people to be educated, informed. They need to be advised, oriented. They need to be counseled. Those are the things that we need when we talk about health promotion. By so doing, then you will talk about preventing disease. Role model. We are the ones to do that. Health professionals. The promotores de la salud, we have a bunch of them here. I see one here from Texas A&M, We have promoters, they're here. They learn in order to teach, educate. Physicians don't go to the colonia. When people need education in terms of being knowledgeable of what they need to know in order to promote health, frankly, in the medical office, there's no room for that. Nurses don't have time for that. No time for that. But here, there's a lot that we need to do. Now, I said I'm going to be very, very practical. When I came here to the Valley 7 years ago, I came from California. I was at the time the chair of Cancer Society, and the motto there is early detection of what? Cancer. But when I came here to the Valley, the capital of lifestyle disease, give me one, don't sleep on me. High cholesterol, diabetes, say it loud. Diabetes, type 2, cancer, obesity, overweight, heart disease, is there? Listen, those are lifestyle diseases, are the diseases you can prevent. You educate people so that they may prevent it. You make them aware of the disease. Those are the list. Even HIV is a lifestyle disease, in case you did not know. So we started this program here. Whatever you do, do it for what? For health. Whatever you do. Actually, I was quoting the Bible. The Bible says, whatever you do, you remember that, Pastor? Listen, The holistic approach is about balancing. When we talk about health promotion, it's about balancing. We need our life to be balanced. Balance in all aspects. See, I'm going to zoom forward. I'm in 2000, I'm helping people, all of that. Listen, we're here to empower people when we talk about health promotion. We empower them with the message in such a way that they will take control of their own life. They should be able to make sound decisions. They take control, they own their own life because of the information that they have received. And when they don't receive it, lifestyle become a burden. They don't do it the right way. So this is the convention charter in Ottawa that was in Canada some years ago. They made some decision in order to do health promotion. If you need this slide, I can make it available to you. Now, this is the physician pledge. Physician pledge. I went around it and I created the health promotion pledge. We want to make that. We're going to make it. We're going to make it. You see, at the end, maybe we'll talk about this pledge here. When we finish medicine, Dr. Cooper and I, we've known each other for many years. In our days, we had to do what we call Hippocratic oath. In a nutshell, it's about not doing harm to the patient. Usually we think of the physician. Not doing harm means that maybe you did the wrong amputation. Not doing harm, you prescribe the wrong medication. Not doing harm, it means that you, you did something not adequate, the law is after you. I got news for you. Do you know that if you do not empower a patient with the right message of health promotion, education, you are doing harm to that patient. You are doing harm to that patient. So we need to do that. We need to practice. All the school physicians, in the technical school, nurses, you need to have the background that will allow you to concentrate. Let me make a statement. Maybe it's the first time you're going to hear this with Rio Grande Valley. The most important health intervention deeply expressed here in the Rio Grande, I've been here for 7 years, is called basic health education. I have navigated all the colonias, all the counties, the rural places. Believe me, is sorely needed basic health education so that people may promote their lives, so that they may avoid disease. I'm not going to waste a lot of time here, but what I'm going to tell you is that, here, let me focus. I'm from Cameroon originally. I'm not going to talk about Cameroon now. Let me talk about the valley. We're here. We're here. Childhood and adult obesity, those are the picture here in the valley. Sometimes I go somewhere in the mall, I go somewhere, and I see the pictures. Health education is needed. I was in the bank last week, in Walmart. And a lady came, stood right in front of me, and I was texting, and then I realized that someone in front. I just snapped a picture, and that's the picture. Yeah, but it was just, you don't know who he is. I don't even know her, So don't worry about that. Listen, the statistics are staggering every year. Can you even imagine 1 in 12 individuals has diabetes in the United States of America? But here in the valley, how many? What is the statistic? This is alarming. It's statistically significant, highly significant. We need to do something about that. What does it mean? Health promotion, disease prevention. What does it mean? Basic what? Health education. I'm going to be finishing soon. Usually I will quit my presentation. I don't finish. Here, I was actually in a convenience store when I saw someone that I know. And he was grabbing a lot of packs of refrescos. All these drinks. And I got closer and I looked at it. It was Gatorade. Gatorade. What do we need it for? He looked at me like I was a stupid man. According to himself, I did not understand the meaning of Gatorade. Unbelievable. That's what he had everywhere. He said that this is what gives me strength. You see, Michael Jordan was so strong. Shaquille O'Neal, that's what I need to be strong. This man was loading himself with all the unnecessary electrolyte, potassium, sodium. You should expect him to be really a mess in terms of health. Nothing beats Gatorade, because they say that. That's the right message for them. And we need to correct these messages in the colonia, in the region. People, they don't know. They really believe false messages. And someone needs to educate them. Gatorade is now the shoes. Gatorade is Michael Jordan. You're not going to put these shoes and then become like Michael Jordan? It doesn't make sense, but there's some people who believe that. We need to help them. They really believe that. Gatorade. I didn't even know about this thing. As I investigated, then I realized that there's so much false messages. Listen, we need to empower people with the right message. We need to correct what is false to make them believe what is right. This is our mandate. You're not going to jump like Michael Jordan because you drink Gatorade. It doesn't make sense, my friend. I'm going to be practical, but I'm going to finish with this. So I'm glad, because we started a program here in the Valley called Free Community Health Expo. What do you read? Early what? Listen, read. Early what? Detection, read. Testing, prevention, education. Everything is early. Early. Not just for cancer. All the lifestyle disease. As we were going to the community, people were mocking us, they were insulting. What do you think you are? You what? San Martin de Porres, they began calling me like that. That we do just need to help the community. No one wanted to support because of what we were doing to help the community. Listen, I'm really glad because Dr. Chance, he's the one who initiated this program here in the Valley with me. And as we started with one student from UTRGV, a pre-physician assistant student. He was coming, and then he told his classmate, would you like to know how many volunteers we have all over the Valley? Dr. Chance, how many? Over what? Over 1,000. Over 1,000 now, they're coming. What do? We go out, no marketing, no none of that. We do the testing. We need to do the testing in order to create a stage that would allow us to analyze, advise, counsel, refer even patient in the right place. So this is very important. We focus on medicine, dental, and then eye. Those are the major routes, especially for diabetes. And this has been working in such a way that things have changed. See, Many institutions got involved. Listen, I'm talking about empowering people with the right message. The student themselves will learn. They will get the message, and then they will be able to counsel these people when they come to our event. And it's quite something, when you go out and then you realize that they're doing it. You see, the students from the university, the nurses are coming too. The physician, medical students are coming. This is so important. How are we going to help people prevent health disease in this region? How are we going to promote health? One physician was a local physician, a friend of mine. He said, I don't know what to do. They come to my office. Before I even open my mouth, they already know what I'm going to say. They even express it better than me. You know what? Maybe they don't listen to what you're telling them. Change your message. Change your ways. Just give the prescription. The next date of appointment, that's it? No. Change the way. Change your message. Change it. See, those are the students now. They learn how to advise on lifestyle disease. As we go out, they're the one doing it. They speak Spanish, English, no problem. They do that. See, those are the physician assistants. They go, they do it now. Last time we went to, all these students, they come, they do the testing. We need to create a culture, I would say a new culture of health in the Rio Grande Valley. A new culture of health. That's why this event is so fitting. We do to be able to have a summit like this. It's a great start, and we need to empower it, for the future. You see, we go out and educate people. I'm talking about being practical. Practical. They learn in order to go and teach other people in the community. See, this is a group here, from different schools. There's no rivalry here. We mingle, we get together to take action to help those who need. And everything is about basic what? Health education. I told you from the get-go, from the beginning, that when we talk about health promotion and disease prevention, there is a common denominator, which is health education. And I've been using this formula everywhere. Maybe you can help us here. I don't know. This is a video. Can you empower it? If it doesn't, that's okay. We'll just, that's okay. But here, 2 weeks ago, we went to La Sara. I've never been to La Sara. Somewhere there. They just went with the university. And then it was such a great moment to see some of my colleagues from the nursing school, from different nurse practitioners, with the physician assistant, with some medical students, together. We're going to promote health. No prescription, no medication, just counseling people based on the analysis of the data that we collected and then to help people. So we need to do more of this. We need to be more distant from just giving medication, but counseling, giving them what they need in terms of the right message. You see, I was stunned here. Just some of my students, they never done it before. In just less than 1 hour, they learn how to advise in health promotion and education. And people would come, they will sit down, they will counsel. This is actually what they need. And we need to do more of this event here in the valley. This is what will bring change in our region. Health promotion is not about disease medication prescription. It's really educating. It's about empowering people so that they themselves may take control of their life. So I don't know if you have any question. If I have time, maybe 2 or 3 questions. If not, the next person will come and take charge. Any question? Any ideas? Anything? Okay. Thank you.
Thank you, Doc. Thank you. This is the last presentation for this symposium. The organizer of this symposium, Dr. Cooper, is going to present obesity and lifestyle therapeutic. But let me talk to you more about Dr. Cooper. Dr. Cooper is the founding member of the Latin American Lifestyle Medicine Association. That is an association that was needed because we really need to use less medication and help on the prevention of these chronic diseases. Dr. Cooper also is a founder of Cooper Wellness and Disease Prevention Center, Cooper Internal Medicine, where she practices here in this community. Dr. Cooper also is a member of the American College of Lifestyle Medicine, and she's pursuing to become a board certified in lifestyle medicine, which is an excellent. So, Dr. Cooper. Thank you.
Thank you very much, Dr. Griego. All right, I have an announcement. All the medical professionals who are doing CME, remember to fill in your evaluation forms and leave at the back with the audio person. So if you're doing CME, fill out your evaluation at the end of the conference and leave that. I want to thank you for staying to the end of the conference. I know some of us have had a very long day. For me, I woke up quite early and I'm still here. Now my talk will be on obesity, but usually with lifestyle medicine, it's a one prescription fits all. Now, if you have diabetes and I have to give you a drug, the drug I give to you will not be the same as what I give to someone with hypertension. But with lifestyle medicine, it's essentially the same. And you have listened and heard a lot on lifestyle medicine. Let me see what happened to my slides here. ¿Qué pasó? Alrighty. So in 1980, we had 7.5% women who were obese, and 2008, that number has doubled. The same with men. And if we continue, you're going to see that it is a growing problem. Now, if you're overweight, or patients who are overweight, tend to die sooner, 10 years earlier, than those that are not obese. And let's look at the countries. Alrighty. So if we look in Japan, 1 in 20 is obese. As a matter of fact, a study was done that showed that Japan is the healthiest country. And America, as I mentioned, is at the 26th. Now, in the United States and in Mexico, 1 in 3 is obese. But when we add obesity and overweight, the percentage increases. So, I'm sure you've heard about BMI. How do we determine who is obese or who is overweight? So BMI is just an index that is used depending on your height to determine a healthy weight. So if the BMI is over 25, then you're overweight. If it's over 30, that's obesity. But then we classify obesity, class 1, class 2, and class 3. All right. So we mentioned those statistics already, that we have a global problem with obesity. Now, this is the map of the world, and as you look, you can see there that America is the most obese country. So, and this is where we live. We're bringing home closer. We see a lot of red states there, meaning that we have a lot of people living in this country with the problem. Obesity combining with overweight, about 70%. The children, in every age group, you can see that our children are obese. Now, with obesity comes many different problems. Why are we so overweight? I know Dr. Dysinger mentioned some statistics in his talk earlier on, but let us look. Why are we so overweight? Total calories. Over the last 40 years, we have increased our intake of calories. We're now consuming calorie-dense food, which are processed food over fruits and vegetables. We have added salt, 10% increase. Flours and cereal, and that is processed flour, 42% of increase in consumption. Then look at added fats and oil. How much do we see there? 66%. Look at vegetables. What's the problem there? We're not consuming vegetables. So these are some of the factors why we are so obese. All right, let's look at that. Now in 1970, the average person was consuming 2,100 calories a day. But over time, you can see a linear rise that we're doing in 2010 over 513 calories. And if we continue to move that line, you're going to see today it's even more. For you to gain weight, you need to consume 500 extra calories a day. So if that is happening, then you're going to see that we're going to be a nation with a lot of obese people here. And this is the same. In 1971 to 74, we had 15% of obesity in our country. And look at the line. Same statistics. 38%, 2013, 2014. Now look at the similar statistics. Shift in food environment. You can see that in 1970, the number of calories that each person was consuming, similar to the one I showed you before. 2057, 2008, it increased 26.74. Added fats in this one says 55% increase. In 1970, the average person consumed about 56 pounds of fat per year. And in 2008, look at the jump. The same thing with sweeteners and added sugar. So this is the reason why we are so overweight, one of the factors. With obesity comes many problems. You all know that. In every organ system, there's a problem for patients who are overweight. I want you to take a picture of that slide. I'm just going to go through some of them. Obesity increased the risk of heart disease. We all know about diabetes, hyperlipidemia, arthritis, gynecological problems. But let's look over to cancer. Obesity does increase the risk of cancer. For you women, for us, obesity increased the risk of endometrial cancer by 6-fold, 6 times. And for breast cancer by 3-fold. So who wants to be obese then? Does anybody want to be obese? What do you think? Absolutely not. So as healthcare providers, we need to see that this is a problem and we need to take care of this problem. All right. So this is essentially saying the same thing. You see, with less BMI, normal BMI, the risk of death is low. As the BMI increases, then the risk of dying from any disease, heart disease, pulmonary disease, that increases. So this is a huge problem that we must address. All right, these are the classes that we discussed earlier on, so I'm going to skip this slide. Alrighty, so we talk about BMI, but there's also another measurement we can use to determine who are overweight and who are not. We talk about the waist circumference. We have it because, you know, there's some patients who have big bones or a lot of muscles, and it's not fair to use the BMI to determine if they're obese or not. So we can use the waist circumference, all right? So the normal should be less than 35. All right, how do we measure that? Providers. So you try to get the iliac crest, the top of the hip, and you go across, and there you measure the BMI, the waist circumference. All right, so we looked at statistics, we looked at problem. So how do we solve the problem? What do you think? You're being very quiet. How do we solve this obesity epidemic? Lifestyle, right? All right, because you guys were listening, and I told you the treatment is essentially the same, right? So, comprehensive lifestyle intervention. And I'm going to talk about 3 different factors, and you've heard them already. You listened to diet, dietary therapy, regular physical exercise, and behavioral. So let's briefly go through. Now, I want to discuss the diabetes prevention program. This is a program that Dr. Dysinger mentioned it this morning, where 3,200 patients were studied. These patients were obese, and they had prediabetes. So they were put into 3 groups. 1, placebo group, 1 was given metformin, and the other group received intensive lifestyle modification. So they had a series of counseling sessions the first 28 weeks. They were placed on diet, reduced calorie, low-fat diet, exercising daily for 150 hours per week, and the goal was to lose 7% to 10% of their body weight. So, what do you think happened? Because I think Dr. Dysinger mentioned this morning. What happened? All right, so this is the result here. All right? You can see that the group that didn't receive any medication, no lifestyle intervention, they did not lose much weight. The group that received the medication, metformin, they lost some weight, but the most striking difference was that the group that was placed on intensive lifestyle modification lost the most weight in 6 months, and they maintained the loss, even though you can see that some regained the weight. Alrighty. Now, the study also showed that the risk of developing diabetes was most decreased by 58% in the group that was placed on intensive lifestyle modification. This shows more or less the same thing. You see, even though there was an increase in weight gain, the lifestyle patient reduced or gained less weight in 4 years. Now, many of you know that I practice lifestyle medicine in my office, and I see the same thing happening. I can give you the story. I had a 25-year-old gentleman who came into my office, and he was weighing 400 pounds. His blood sugar on initial visit was 390. His hemoglobin A1C was 14, blood pressure was high, cholesterol high, and all of that. He was placed on a 12-week program using dietary therapy, exercise, and counseling. He lost 90 pounds, improved his blood pressure, improved his diabetes, got off many of his medication, got his A1C down to 5.3. So this does work, but you have to want to do it, and the patient needs to be convinced, and we have to work closer together. So let's look at dietary therapy. I'm not going to go in detail because you listened to that already this morning, but in the study we had 4 different types of diets. 1 was very low-calorie diet, 2, meal replacement, 3, low-carb, high-fat, and then low-calorie diet with low glycemic diet, the same thing. Let me go through the differences with these 4 diets. Alrighty, so the very low-calorie diet, which I don't use, the patients are restricted to between 400 calories to 800 calories a day. That's almost eating nothing. Of course, there's faster initial weight loss, greater total weight loss, greater loss of lean muscle, and higher risk of weight regain. So they lose the weight fast, but they also gain it back fast. So I do not recommend this one. These patients take mostly liquid diet, but this is not recommended. Now, the meal replacement diet, this is where the meals are planned, they're pre-planned. What happened here is that you determine how much calorie you want to cut in these patients, how much calorie you want to reduce. The portions are controlled, and of course, we limit the calorie-dense food. There is, of course, increase in weight loss, and this is also effective. All right. Now, this diet, I wanted to mention this type of diet. These are several diets. This is the Atkins diet, the paleo. Have you heard about this diet? I'm sure everybody has heard about it. So, it's a low carb, but high fat. There is, of course, significant weight loss in 6 months, but there's a high fat intake. This is not generally safe over time, and there's high cardiac rest. Any questions? All right, this is one I like. Low-calorie diet. In this, the patient will consume mostly low-fat, whole grains, fruits, vegetables, nuts, and seed. This is the Ornish diet. It's also low glycemic. There is a greater reduction in cardiovascular risk, reduction in LDL, and of course, better reduction in hemoglobin A1C. This is mostly the diet I use, and as Dr. Dysinger said, you're going to eat more plants. Not everybody can be vegan, but if you eat more of the good thing, then you're going to improve your health. All right, I wanted to discuss this research on the patients, some patients in Sweden that were placed on the low-carb, high-protein, or high-fat diet. So there were 43,000 women ages 30 to 49 who followed this diet for about 15 years. They were given a score, dietary score from 1 to 20, based on how closely they followed the diet. And the results show that 60% increased risk of cardiovascular was seen depending on how compliant these patients were to the diet. So, therefore, those patients who follow the diet closely increase their risk for heart disease. So therefore, the conclusion is that the low-carb, high-protein diet are associated with increased risk of cardiovascular disease. So we have to be very careful what diet we suggest to our patients. All right? We do not want to suggest so much of a high-fat diet, because then we'll be increasing the risk of cardiovascular disease. All right. Now, there was another study comparing low-fat group with low-carb. So they separated this out into low-fat and low-carb. And as you can see, there was no statistical difference between those patients who were placed on the low-fat versus the low-carb diet. They both lost significant amount of weight. In 6 months, there was some weight regain, more or less the same. All right. Now, you know that we advocate whole grain, plant-based diet. So there was another study done, it's a huge study, over 300,000 patients. They were followed for 6 to 10 years. And there was a relationship between dietary fiber intake and adverse cardiovascular outcome. Now, if you notice on the horizontal axis, we can see that the cardiac risk decreased with the more fiber that the patient ingested. We usually recommend for female 28 grams per day of fiber, and for males about 35 grams. I'm not going to go into detail, we're just wrapping up here, but we know that high fiber diet has lots of health benefit. Lowering blood sugar, lowering cholesterol, of course, lowering the weight, keeping you feeling fuller longer. So then that will improve your health outcome. Alrighty. So what then is a successful diet? Because we discussed 4: low calorie, meal replacement, low carb, and low glycemic. Which, in your opinion, is the best diet for your patient? What would you say? Anyone can answer. Which diet do you think we should give to the patient? What do you think? All right, so the diet that you think the patient will be compliant with, that's one. However, the diet that will help in reduction of weight by about 10%, the diet that will reduce cardiovascular risk, the diet that will reduce hemoglobin A1C, reduce blood pressure, reduce triglycerides, and reduce premature death. This is the best diet for the patient. You know, it is very difficult discussing lifestyle medicine with a patient because usually we have our culture. You know, a patient might be on a certain diet for so many years, and now you're telling the patient to change. So we have to sit with that patient and design a diet that is the best for the patient. Not all of our patients, as I mentioned before, can be totally plant-based. Now that's where we want to move them. But every patient is different. So, physical exercise. Now, you had extensive lecture on physical exercise earlier on. So I'm not going to go through a lot on physical exercise. Alrighty? But we know that physical exercise can reduce blood pressure, lipids, and vascular fat, and is good for health. Now, when we talk about obesity, let's talk a little bit about physical exercise. Is it the fatness that we should address, or is it the fitness? How does physical exercise play in our health? Is it that we have more health benefit if we reduce the fat, or if we increase our cardiac endurance? So we had 16 twins that were studied to look at fitness versus fatness. It showed that the twin that were inactive had more high-risk fat, vascular fat, and more intramuscular fat. Physical exercise is important for health, increasing cardiac endurance, as well as to decrease weight. I'm going to go through this very fast. Now, how important is it for physical activity in initiating weight loss initially? You know, some people will want to lose a lot of weight and they will be exercising, but the weight loss will not be there initially. It is easier for one to use diet to lose the weight than the exercise, but physical activity is very important. Exercise does not significantly improve short-term weight loss, but it improves cardiac health. So we need to exercise for cardiac health. Let me skip this one. Now let's look at maintaining long-term weight loss. This is where physical activity is vital. And remember, in the diabetes prevention study, that in the first 6 months we had a significant drop in the weight, but over time we noticed that there was some weight that was regained. There's a study done looking at physical activity and the long-term weight loss or the regaining of weight. Now, if you look carefully on the top line there, we see that those patients who are exercising less than 150 minutes per week, you notice they had the most regain in their weight. Now, the bottom line showed that those patients that were exercising over 300 minutes per week had less regain. So what would you draw from this? If you want your patient or yourself to lose weight and not to regain so much of the weight, how much should they exercise? More, right? At least 1 hour per day. Alrighty. Now we're going to look at, remember we looked at diet, physical exercise, and behavioral therapy. How do we get our patients to maintain weight? I'm sure that many of you here in the audience who probably work with patients realize that you work along with the patient, you put them on a diet and exercise, they lose the weight, but what happened later on? They regain the weight. I have this patient, 65 years old, came in the office. He was very overweight, hypertension. He had arthritis. He lost about 60 pounds. He kept that off for about 2 years, was doing well. And then He was not seeing me that frequently, and then he regained the weight. So therefore, here we can see that behavioral therapy is very important. And the more frequent the patient sees the therapist or the doctor, the less weight regain we'll see. And I think some of our speakers discussed that. So it's very important for us to keep in touch with the patient. The patient needs an accountability partner. The patient needs encouragement for them to be compliant. Alrighty. So then, somebody walks in the office and is requesting lifestyle counseling, or the patient is obese and we want to work with the patient. We have to sit together. We have to see the patient's readiness for change. We have to work together. It has to be a shared decision making, or else this won't work. You know, many times patient might walk in and you say, okay, I think Dr. Bryce gave an example today, where the patient walk in and we just make a diagnosis and we say we're going to give this. The patients are not usually compliant. They have to have the readiness for change, and then they will make the change in their diet, they'll become more active, and we can move from there. So therefore, these are some of the things we have to look into when the patient comes into the office. Why are they overweight? How long have they been overweight? Have they had the problem before? Have they attempted to lose weight? And as I say, are they ready? And then we can provide advice on lifestyle. We can give the recommendation for treatment, and then we can work along with the patient. Now, behavioral therapy is so important in helping our patient lose the weight and maintain the weight loss. It is said that you are what you think. And then we can look at that triangle there: thoughts, feeling, behavior. And then we go back in a circle. So this is why behavioral therapy is important. Dr. Bryce spoke this morning about the real cause. We have to sit with those patients and see, why are they overweight? What are their thoughts on food? What are their thoughts on lifestyle? How can we move them? How can we get them to change? Are they ready to be engaged in weekly counsel? Are they ready to be engaged in monitoring their weight, weighing every week, weighing every day? Are they ready to document what they're eating? Because if we don't get them involved, then they're not gonna lose the weight. So therefore, in my practice, for example, we have group session. Patient comes in once a week. We work together in a group. So I have someone who counsels on exercise, on diet, and the medical problem. Studies have shown that the patients who are willing to be in the group therapy tend to do better. And as I mentioned, the more frequent the group therapy and the more frequent we are in contact with the patient, then patients tend to lose the weight and maintain the weight loss. Now, how big should the group be? That is quite dependent on you. Some studies have shown that the larger groups are better, but in the group, as I mentioned, we need to have a dietitian, psychologist, somebody with exercise, and a health professional. And in the diabetes prevention study, the therapy went on for the study was for 4 years, but the first 26 weeks, they had frequent therapy, frequent behavioral therapy group meetings, and then that was prolonged. And how long should the session be? That's depend. But here it says it can be 60 to 90 minutes. All right. I think I showed this slide before. Alrighty, so we can see here that obesity is a problem. And we have to approach it looking at diet, exercise, and behavioral therapy. And as I mentioned, that the patients need frequent or continuous counseling. How do we reach those patients? Now, there are many ways of reaching the patients. We have online, web-based, patients can come into the office, telephone-based, and but the most important thing is that we are in touch with the patient. Now, what is the future direction? What should we do in order to make sure patients lose weight and maintain the weight loss? I believe, and I think we're all doing this, to make BMI a vital sign. We must discuss weight with our patients. And we should use technology to reach a greater population of patients. And we should provide ongoing reinforcement to prevent the weight gain. Any questions? Yes.
I haven't heard any discussion yet about food addiction. And I'm wondering, as part of this therapy, we really have to see how certain additives or components are those addictive pieces that, as we look at the salts and the sugars and certain components. But I think the word addiction needs to perhaps come into the language.
I think that is where behavioral therapy comes in. We have to see the patient's thought on food. I had a patient once, and overweight, hypertensive, arthritis, and I could not get her to lose weight. And then one day we sat in the office and we discussed the problem. And she told me she was essentially addicted to food. She said when she was growing up, she had no food. And now that she's able to purchase, she's able to control what she eats. She just can't stop eating. She has to make up for what she missed in the past. And that is why the behavioral therapy comes in. We have to see their thoughts on food. Why are they overweight? What type of food are they eating? Are they really emotional eaters? Do they have to eat, or they eat when they're not hungry? And that is why it's important for us to work with a psychologist in these group sessions.
How much of it is emotional and how much of it is chemical?
That's a good question. I think it's both. Because you're so right that some of the foods we're eating, they're additives added to these food that cause us to want more. So we just can't stop. Dr. Bryce gave a story to a patient who couldn't stop eating chips. She was addicted to chips, and as a result of that, she had an autoimmune disease that essentially caused her death. So that's a very good point.
Can I just ask one more question?
Yes.
So are our fat cells, do they ever go away, or are they only reduced with the diet? So the number of fat cells remain constant?
Really, I don't have studies on that, but I really believe the cells are there reduced with a diet. What do you think, Dr. Dysinger? The fat cells, are we reducing the cells or reducing the size?
So my understanding is fat cells, you do not get rid of fat cells, so you reduce the size, they continue there. But just as far as emotional eating, I think it's a huge problem. I highly recommend a program called Mind Over Eating. You can look it up, that does a really good job of addressing emotional eating. But food companies are very good at knowing exactly what our body likes. So they'll adjust the glycemic index, they'll adjust the salt and the fat content to sort of go after that sweet spot or that craving. And the book Sugar, Fat, Salt talks about that very clearly. So they definitely work on that addiction piece. And I really believe, a lot of what we do in our clinic is specifically set up to try to help with food addiction. I actually personally believe that everybody is addicted to food at some level. I know I am. I know I'm addicted to food at some level. And I actually think everybody is. Some people more than others. Some people it's a terrible addiction. I mean, they will be at home in night, lying in their bed, get a craving, actually get up, go to their car, drive someplace, get what they're craving, and eat it. I mean, it can be really hard. It can be a tough addiction. But we know how to fight addiction. That's why we have support groups. That's why we do environmental changes. There's a variety of things, and food addiction, as a general rule, is not as powerful as, say, cigarette addiction or alcohol addiction or something like that.
Because the focus is on opioid, but I'm wondering
Right.
if we need more focus on.
Well, obviously with the obesity epidemic that Dr. Cooper-Dockery talked about, and the diabetes epidemic that Dr. Bryce talked about, and other areas, we clearly need more. And then the hard thing about food is that you have to eat, right? I mean, with opioids or alcohol or cigarettes, you can actually get rid of them. Food you can't get rid of. You have to eat something, so it becomes more complicated from that perspective.
Thank you very much. Any other questions? Yes.
How do you simplify for someone who is illiterate, say who can't read, or have the ability to go online and look up things like that, and is mentally disabled?
Simplify what? You mean the lifestyle council?
The diet.
Well, what I start doing nowadays, rather than saying don't eat this and don't eat that, I'll ask them to eat more of this because of the nutritional value, the decreased calorie, decreased fat in the plant-based diet. I don't use a pyramid. I don't necessarily use quantity because they can eat a lot of plant-based food and do not gain weight because they're eating a lot of fiber that will keep you fuller longer. And remember that these foods are low glycemic foods, low in sugar, low in calorie, and high in nutrients.
So my question is, how do you simplify for them, for somebody who can't understand or who won't even remember?
Okay, so for example,
Picture charts or something, give them big picture posters or something?
not necessarily. I think it's very easy to understand if I say, eat 2 cups of green leafy vegetables. And I'll tell them, you can do mixed greens, you can do lettuce, you can do this or that. Don't eat a lot of white flour, white sugar, rice. Don't eat fried foods. I don't see it as complicated. And then exercise. Walk 30 minutes a day. If it's raining, still walk in your home. So it is really not complicated. I think the problem is compliance. How do we get them to be compliant when they're accustomed to living a certain way? The way to get them to be compliant is to have them see you frequently. Somebody has to follow up, whether the office calls them, and my office does that, and say, hey, Mrs. Sanchez, how are you doing? Did you remember to drink this amount of water? Yes, you have to constantly coach. It could be by telephone, it could be by email, but if you don't constantly coach them, they go right back in the lifestyle. They gain the weight back, the sugars go up, so you have to be constantly coaching them, yes.
My next question is with regards to the medication metformin. There's so many controversies about that, and I keep seeing it mentioned there, especially in relation to weight loss.
Yeah, metformin, one of the side effects is weight loss. So that is one of the reasons I'm thinking we use this here in the diabetes prevention program because these patients were pre-diabetic and they're overweight. And one of the side effects is some weight loss. Anybody else? All right, Dr. Greger, you can take it over. Thank you very much.
Thank you for staying till the end. We really appreciate your support. to this initiative. This is the first event of this kind that we have, but it's not going to be the last one. We are going to continue having this type of conversation because that's what we need. And I want you to remember this number, 2,200. 2,200 persons die every day here in the United States due to cardiovascular disease. Those patients die taking medication. They are receiving medication and they die. We can prevent at least probably 50% or more of those deaths if we promote this type of education. So I hope that today we were able to deliver information that you will put in place and you will continue amplifying this knowledge by getting in touch with everything we do and getting in touch with more information about lifestyle changes. Doctors, nurses, you can apply to become board certified in lifestyle medicine. It's a board that is available. You can amplify all this knowledge. We can provide you all the content that you need, but we need to improve this. One of the speakers said that we need to try to make South Texas a blue zone. We only have one blue zone here in the United States, which is in Loma Linda, and there in California, the Seventh-day Adventist. We only have 6 blue zones in the world. And we have one in the United States, one in Costa Rica, and the other 4 they are in the Asia and all those countries. So we need to work together. And that's why I really congratulate you for staying here and help us to continue with this movement. Thank you and God bless you.